So let's look at just paying patients and seeing what happens, or various ways to incentivize them. So here's a table running through some studies. Let's look at the first two rows that are both, if you look at the left, they're both for oral naltrexone, okay? And so this is trying to help people with opiate addictions. So the first one lasted 3 months, and they gave the drug 3 times a week, and then they gave vouchers of up to $1,000, a little over that. The outcome, so that was the incentive, $1,000 voucher. The outcome was the number of doses taken. So do they keep their dosage up? And they looked at the incentive versus the control. And in the incentive, the number of doses was 21 versus 11. So almost double the amount based on giving an extra $1,000. Okay. A second outcome they looked at was the percent of opiate-free urine samples. And there, again, the incentive had an enrichment of 14 versus 9. So 14 were opiate-free urine when they got the $1,000 versus 9 without. So this is an interesting example where the patient should have, it seems, enough incentive to get off drugs themselves because of the deleterious effects it's causing in their life, but that alone doesn't do it, and giving them an extra $1,000 gives them enough incentive to help. So below that, we're looking at injectable naltrexone, and there, it's not really the route that's different that we're looking at. They did it for 6 months, so the dosing was only once per month. So there is a difference in how hard that is for them to do, but the incentive was very different. They had paid job training. And so you can imagine this is a few things you're giving them at once. You're trying to train them so they can provide for themselves, but you're also paying them. And so they got $10 to $20 an hour, which was up to almost $5,000. So here, the money value is basically 5 times as much. The outcome, the main outcome they looked at was percent injections accepted. So again, are they getting those injections? And the incentive versus control was, the percent was 87% versus 52. So not a double enrichment, but that would have, from 50, that would have gone up to 100, but 50% enrichment. So 50 over that, 50% over 50 would have been 75. So that's about a 75% bump off no incentive. A second outcome they looked in that was the percent of opiate-free urine samples again, and there it was 72% versus 65%. So if you compare these two, which is working at the same population but with different things, you see that the one that actually paid them more overall seemed to have less of an effect. And so we'll see this, that paying more money doesn't necessarily do the job. So there's a few differences here. There's not one difference, so you can't say there's one cause. For example, the top one only lasted 3 months, so it was a shorter time that they had to do this. If you were going to multiply that $1,000, it would really be 2,000 versus 5,000. So still, the second one was paying more, but the lower amount got more done in that study. Then we move to the third row, looking at antiretrovirals for HIV. This one lasted 3 months, and the dosing was 2 times per day. Again, they used vouchers of up to about $1,000. The outcome they looked at was the percent on time MEMS cap openings, and the incentive versus control was 78%, 78 versus 56. So about a 50% gain. And then they had a second outcome of HIV RNA levels, and there it was about 7,000 for the incentive versus 5,500 for the control. So maybe I'm doing all this in my head on the fly, about 20% gain. The next row is warfarin versus anticoagulation, 3-month trial. It had various dosaging, and here they had 2 trials within this one study. The first trial, they had a cash lottery that averaged $450, and the second one had a lower number of 270 on average. The outcome they were looking at is the percent of incorrect doses. And in trial 1, so this is the higher cash trial, the incentive versus control was 2.3 versus 22. And the second trial had 1.6 versus 22%. So again, we're seeing here that the lower cash payout, the lower cash incentive, actually had a greater effect. They still had massive effects, right? So without any incentive, the control group had 22% of incorrect doses. And when you had an incentive, that dropped that tenfold to 2% incorrect doses. And somehow, if you offered less money, $270, it was 1.5%. The second outcome they looked at was percent coagulation tests out of range. And in both of those, you saw drops, which actually is flipped from the other one. So the trial one, higher paying one, 12% were out of range in the incentive versus 35%. And in the trial two, 40% were out of range versus 65%. So you see, I don't have the N here. Some of these issues might be with the size of the trials, because you can see that the control groups differed largely in their percent coagulation test there. And then the last one is nicotine gum for smoking cessation, a 4-month trial. And they were supposed to take it more than 12 times a day. The incentive was $70. And they were looking at the percent days that you were adherent to that. And the incentive trial had 66% adherence versus 25% adherence, so a huge gain. The second outcome they looked at was percent smoking status 1 week after the intervention. And here you see that the incentive versus control didn't differ. Okay, so the incentive group was 24% at 1 week out, and the control group was 23%. So there's a lot of studies that show this, but this is one example of when you pay people and you can see an effect. When you stop paying them, that effect seems to disappear instantly. So the question becomes, is it cost effective to pay them forever? And is that the best use of those resources?